Good evening, everyone. We're going to get started with our View from the Trenches session, What Will You Do Monday Morning? My name is Andrea Barrio. I am a breast surgeon at Memorial Sloan Kettering Cancer Center in New York, and I am accompanied, you all know, Dr. Tolaney. And we're going to get started, and I'm going to go through a couple of slides, and then we're going to get started with our discussants. So we decided to break this up in kind of compartments or topics that we thought were of interest that we could discuss. The first will be a local regional topic where we discuss the Alliance Multiple Lumpectomy Trial, nodal recurrence in clinically node-positive patients after neoadjuvant chemotherapy, and then the conventional versus hypofractionated proton RT trial. We're also going to spend some time discussing the positive trial, and then I think everybody's favorite topic, the HER2 low and the ADCs, and specifically talking about a pathology perspective for HER2 low testing, as well as ADCs, including sequence and timing in HER2 low patients. And then finally, we're going to end with management of hormone receptor positive, HER2 negative advanced metastatic breast cancer with treatment options after CDK4/6 inhibition, and I defer that entire discussion to my medical oncology colleagues. We have a really wonderful group of panel members, which I'll be introducing as they come up to speak, but I do want to make special mention of our patient advocate, Vernal Branch, who's with us today. She is a 29-year breast cancer survivor with experience in creating outreach programs in California and Virginia, and she's presently serving on the NCI Alliance and UNC Chapel Hill SPORE, and has been co-chairing for several years the California Breast Cancer Research Program grants meeting, so we're really lucky to have her with us. And virtually, when we need her input, is our biostatistician, Meredith Reagan. She is a professor, Division of Biostatistics, Department of Data Sciences at Dana-Farber, and she'll be weighing in for any statistical questions we have. So we are going to get started with our first speaker. Dr. Mediget Tashomi is an associate professor of breast surgical oncology at the University of Texas MD Anderson Cancer Center, where she is a clinical breast surgeon with expertise in the surgical and multidisciplinary management of breast cancer. And her talk will be quickly followed after that by Dr. Richard Zellers, who is a professor and chair of the Department of Radiation Oncology at Indiana University, and he's also the Associate Director of Clinical Affairs for the Melvin and Bren Simon Comprehensive Cancer Center. Thank you.
All right. Thank you very much for the opportunity to be able to contribute to this session today. No relevant financial disclosures. So my presentation will focus on the following two studies, which were really beautifully and elegantly presented this morning, looking at surgical management of the breast and axilla in breast cancer and answering important clinical questions. So the first is ACOZOG Z11102. The rationale for this study is that historically patients with multiple ipsilateral breast primaries were treated with mastectomy given the high rates of local failure after breast-conserving therapy. However, rapid advances in our diagnosis of breast cancer as well as management has really called this into question in the contemporary setting. And we also know that breast-conserving therapy is associated with improved quality of life outcomes and patient satisfaction in patients who are eligible for this approach. And so understanding the oncologic safety in this patient population is very important. This was a multi-center prospective single-arm phase 2 trial which sought to evaluate breast-conserving therapy in women with multiple ipsilateral breast cancer with the primary endpoint of local recurrence, and the investigators defined the acceptable 5-year rate of local recurrence as less than 8%. Several secondary endpoints were also evaluated and have been reported. The study enrolled patients from 2012 to 2016 and evaluated 204 patients in the final analysis. These were women with early stage breast cancer, 2 to 3 foci of disease, negative margins, whole breast radiation, and specifically patients with BRCA mutations and breast cancer history were excluded. As you can see here, this table represents a summary of the majority of patients in the study, which were found to have 2 lesions, T1 and N0 disease, invasive ductal histology at least one site, sentinel lymph node biopsy, and ER-positive, HER2-negative subtype. The authors found 6 patients over the study period who developed local recurrence, giving a cumulative incidence of local recurrence at 5 years of 3.1%, which is well below the pre-specified threshold of 8%. The authors also looked at local regional recurrence based on other factors, other clinical parameters. However, it's difficult to make definitive conclusions based on the small sample sizes in some of these subgroups. The limitations to this study, several which were discussed previously, are the modest number of patients who were triple negative, HER2 positive, who had 3 lesions and who did not have preoperative MRI. And longer-term follow-up is needed, especially given that this is a predominantly ER-positive cohort with typically late recurrences. Also, as a surgeon, technical aspects to the procedure, operative approaches would be interesting to further understand, as well as the consideration for breast volume to tumor ratio and pathologic assessment. All of these patients were treated with upfront surgery, and extrapolation into the neoadjuvant setting, I think, is an open question. So in summary, overall, there is a low rate of local recurrence in these patients with 2 to 3 ipsilateral breast malignancies treated with breast-conserving therapy, particularly in patients with early-stage disease, negative margins, whole breast radiation, and without a genetic predisposition for breast cancer. So I think based on this data, it is reasonable to consider MRI to determine the extent of disease in this patient population and to guide surgical management. Other considerations are oncoplastic reconstruction, which this may be an ideal patient population to consider this approach to maximize aesthetic outcome, as well as the implications on breast cancer surveillance imaging in terms of conventional imaging with mammography, but also is additional MRI needed. The second study is looking at oncologic outcomes following sentinel lymph node biopsy and targeted axillary dissection in patients with node-positive breast cancer who convert to node-negative after neoadjuvant chemotherapy. We know that in this patient population, approximately 40% of patients will develop an axillary or achieve an axillary PCR. And in this setting, several large prospective studies have evaluated the false negative rate of sentinel lymph node biopsy, finding it to be over 10%. However, these studies also have defined strategies which we can use to reduce the false negative rate and thereby improve the accuracy of the procedure, including dual tracer technique, excising 3 or more sentinel nodes, resecting the biopsy-proven axillary lymph node denoted with a clip, and then also immunohistochemistry evaluation to evaluate for residual isolated tumor cells and determining this to be node positive. This work has led to development of what's referred to as targeted axillary dissection, which is an approach to axillary staging defined as a sentinel lymph node biopsy with dual tracer technique and selective excision of the clipped or biopsy-proven axillary node. And while the technical aspects of these procedures have been well described, there's limited data on long-term oncologic outcomes. It's also, I think, very important to note that axillary staging after neoadjuvant chemotherapy really remains highly prognostic and is increasingly more important as there are several adjuvant systemic therapy decisions that are being made based on the basis of residual disease, and that this is a critical component to determining RCB status. So this study is a retrospective analysis of prospective data from multi-center international collaborative effort from 2013 to 2020. All patients had biopsy-proven nodal disease, axillary PCR, and did not have an axillary dissection. As you can see here, over 1,100 patients were included in the study, the majority of which were white, had clinical T1 or 2 tumors, and 1 disease, poorly differentiated tumors with ductal histology. 54% were HER2 positive, and approximately 2/3 had a PCR in the breast. The majority of patients did have radiation and adjuvant endocrine and HER2 therapy when appropriate. 60% had sentinel lymph node biopsy, and you can see that about a quarter had a clip placed, and the majority of the time the clip node was removed as a sentinel node. In the TAD group, I'll just point out that dual tracer was not required or reported, and 1% of patients did not have the clip node removed. Between the 2 groups, the statistically significant differences noted were a higher proportion of white patients in the TAD group, a higher proportion of well and moderately differentiated tumors, a lower yield of sentinel nodes removed and total nodes removed, and a higher proportion of adjuvant nodal radiation and chemotherapy. The authors reported overall cumulative incidence in the entire study cohort of isolated axillary recurrence, of 0.65 at 3 years. And when comparing between the TAD group and the sentinel lymph node biopsy group, there was no difference. Actually, there were 2 isolated axillary recurrences in each group. In terms of local regional recurrence, the 3-year cumulative incidence was 1.5%, and this was not different between the 2 study groups. And invasive recurrence, which included distant or local recurrence at 3 years, was 7.5%, without any difference between the 2 groups. And I think this still highlights that even in patients with axillary PCR, the highest risk is distant failure. The limitations of this study are that it is a retrospective study that doesn't introduce selection bias. There were differences between the 2 groups, as we noted. I think the extent of nodal disease at presentation and the extent that it is known was not described, although there were a small portion of patients who were N2 and N3. The one thing that would be interesting to note is if isolated tumor cells were classified as residual disease and thus node positive, and if patients received an axillary dissection and were excluded, or if patients were included in the study. And then there were a small number of cases where the clip was placed and not retrieved, and in both groups, and it would be interesting to know if any of the axillary recurrences involved the clipped node. In summary, I think this is really a exciting study that shows that early outcomes from sentinel lymph node biopsy or TAD alone without axillary dissection in clinically node-positive patients who achieve axillary PCR after chemotherapy is oncologically safe, and that there are comparable outcomes between sentinel node and TAD. And of course, long-term follow-up will be important to evaluate this further. Although there were a small number of isolated axillary recurrences, 3 of the 4 patients did not have radiation. I think this is an interesting finding, and at this time, adjuvant radiation should really still be considered while we await results of the NSABP B51 trial, which is looking at this question. And then lastly, evaluation of lymphedema rates in patients who downstage and are treated with this treatment approach without axillary dissection will be important to define, although we would also expect that this would be reduced compared to axillary dissection, and this would be really wonderful for our patients. And that's all. Thank you so much.
As Dr. Zellers is coming up to the microphone, I introduced him previously, but I am to remind you that there is food and drinks available outside until about 6:15. So if you're ready for a drink, I am, and I can't leave the table. Please go out and have one, and that will help this all be more enjoyable for everyone.
I ordered a drink. I'm still waiting for it. Hi, my name is Rich Sellers. It is a pleasure to talk to you today. My topic is post-mastectomy proton radiation therapy. Let me get this. Oops. Oh, there we go. Specifically, I'm going to talk about a trial that was presented today, a phase 2 randomized trial of conventional versus hypofractionated post-mastectomy proton radiotherapy. I have no disclosures. There are clear benefits of proton dosimetrically over photon, as illustrated in these images. With proton therapy, we can hit our target and minimize dose to non-target tissue and certainly to avoid critical structures, as you can see here. However, the ideal dose or fractionation for proton therapy after mastectomy has not been identified. The authors of this trial attempted to answer this question by designing the following trial. In this trial, women who need post-mastectomy radiation are randomized to conventional fractionation, 50 gray and 2 gray fractions, or hypofractionation radiation, 40 gray and 15 fractions. The women were stratified by breast reconstruction or not. The primary endpoint was 24-month complication rate, the complications being grade 3 or greater common toxicity criteria or unplanned surgical intervention. Stats were interesting. It was a combined non-inferiority and superiority trial, but specifically the non-inferiority margin was 10%. This is the consort diagram. 41 patients were treated in each arm. There were no statistically significant difference between the cohorts with regards to the standard clinical pathologic factors. I just point out here that 2/3 of the patients or more had immediate breast reconstruction, and overwhelmingly, it was expander and implants. The authors show that there was no difference in progression-free survival between the two groups. However, the trial was not powered to be definitive in this regard, so this is just an interesting finding. How about toxicity? The only statistically significant toxicity was radiation dermatitis, which was greater in the conventional arm. Not much of a surprise, we see that in whole breast radiation. There was a trend to significance of higher incidence of infection in the hypofractionated arm. But here's the money slide. Complication rate. The rate of complication was 14% in the conventional arm and 19.5% in the hypofractionation arm. This was an estimated difference of 4.8%. Because the upper bound of the 95% confidence interval for the absolute difference exceeded 10%, they could not claim non-inferiority. This is a surprise because we see other studies showing that conventional versus hypofractionation are about the same, or there's a non-inferior with regards to hypofractionation. So what happened here? Well, was it the planning or was it the dose? A dirty little secret about protons is that at the distal edge of the proton beam, this point here, just beyond the tumor, the radiobiologic effect tends to be greater than the standard quoted of 1.1. And if this is not carefully monitored in the treatment planning, that can lead to trouble. 2 such studies, one by Underwood et al., published in 2018, show that there was increased lung parenchymal changes in women who received proton radiation for breast cancer at the lung-chest wall interface due to this distal edge of the proton beam. Even worse, Kralik et al. Reported a very high rate of strokes in children who received radiation for brain lesions. And it was due to large vessel cerebral vasculopathy of vessels that are at the posterior or at the edge of the target. However, I doubt that this is a concern in this trial. These authors were great about designing the radiation, not only that it hit the target, but actually had some skin-sparing effect. So the next question is dose. Was the hypofractionation dose too much? 40 gray times 15 is commonly used in whole breast radiation, so it should be okay in mastectomy, right? Maybe, maybe not, especially when one considers there's very old data that shows a lower dose is as effective. And that data comes from the British Columbia Cancer Agency post-mastectomy radiation trials. This is one of the 3 trials that established the role of post-mastectomy radiation. In this trial, women were randomized to radiation or not after mastectomy, but the radiation was delivered 3760 in 16 fractions. So this is a lower toxic dose than the one that was used. How we got as a field to consider 40 gray and 15 after mastectomy when we have nearly 40-year-old data showing that a lower dose works, I do not know. But remember, these studies were done pre-sentinel node, pre-modern reconstruction, and pre-photon, obviously. So even though this is a negative study, it is still promising. Noam and all reported a 53% rate of reconstruction failure in women who were treated with conventional proton fractionation. This was retrospective. However, we have prospective data. Jimenez and al. Reported a 32% rate of unplanned surgery in women who were reconstructed who received conventional proton post-mastectomy radiation. Kahn reported also 32% reconstruction failures in those who received post-mastectomy proton therapy. So what are the conclusions? Conventional post-mastectomy radiation with photons is still pretty much the standard of care. There's great interest in hypofractionation, and there are studies that are evaluating that. Regards to protons, conventional fractionation of protons is in use now. It is just an extrapolation of the data. Perhaps we should take pause and not necessarily do that, certainly given the high rate of reconstruction failures. Specifically with regards to hypofractionated proton therapy, I would not do that outside of a clinical trial. Mutter and his colleagues should be commended for doing this trial. Even though it is negative, the information from this trial will inform future breast proton trials. Thank you.
Can I
Zeller's slides back up. I just need Dr. Zeller's slides back up. Okay. I'd like to thank our panelists for a wonderful discussion. We thought we would do this by presenting some clinical cases about the talks and kind of opening up a question and answer. We were going to go through these cases, and then if we do have some time, we can take some questions from the audience as well. I could talk about the axilla all day, but I won't bore everybody here because most people don't want to hear it. So our first case, and these are kind of simplistic questions. Some we'll kind of skim over, some we can spend some more time on depending on what we think. This is a 43-year-old female with a right breast, clinical T2N1 invasive ductal cancer, ER negative, HER2 positive, who presents with a palpable right axillary lymph node. She undergoes biopsy of the lymph node with clip placement, confirming metastatic carcinoma. She receives neoadjuvant chemotherapy and HER2-targeted therapy, and she becomes clinically node negative by palpation after neoadjuvant chemo. And so our question to our lone surgeon on the panel is, how would you manage the axilla post-neoadjuvant chemotherapy? Do you ever use axillary imaging to determine candidacy for sentinel lymph node biopsy after chemo?
Thank you. Can you hear me? Thank you so much for the question. I think definitely I would usually will get axillary imaging at presentation and prior at the completion of chemotherapy to help guide surgical decision making. I think for this patient, especially if without a palpable axilla and with what looks like a treatment response, she would be eligible for TAD. It's typically what I would do would be a TAD or sentinel lymph node biopsy.
Yeah. Agree. We rarely use axillary imaging to make decisions at Memorial for sentinel node biopsy and go by palpation alone, understanding that the sentinel node will give us the information that we need about deciding about axillary dissection. And when you do mapping, are you using dual tracer mapping on all post-neoadjuvant patients?
Yes.
That's an easy question, I think. I think if we want to increase the accuracy and try to lower the false negative rate using dual mapping, there's definite evidence from the prospective trials that proves that we should be doing that. I know I don't even need to ask you if you'll localize the clipped node. I already know the answer to that.
Definitely a clipper. Definitely a clipper over here.
But not that I'm biased, we now have good real-world evidence from my colleague, Dr. Montagna, that nodal recurrence rates are low however you choose to do it. So sentinel node biopsy with retrieval of 3 sentinel nodes and dual tracer mapping, or retrieval of the clipped node. And these situations may change for you depending on what's available to you at your facility. And so this kind of brings me to the question, and I won't ask about how many nodes because we know it's 3, but my question, I'm going to skip to the question about what if you can't find the clipped node, which I think comes up a lot, and whether you can't visualize it after chemo or you just, for localization, what do you do in that scenario?
Yeah, I think that's a really interesting question and sometimes can be a challenging clinical scenario. I think that in our institution, we have found that using a two-mark U-shaped clip does make it easier to identify once the lymph node becomes more normal after chemotherapy. So typically that's what we will use. But let's say we don't have that available to us, then I would, if we're not able to localize it, I would not, just localize a random node or something like that. So that we would take the patient to the OR and do a sentinel node biopsy and dual tracer technique, hope that we can get 3 sentinel nodes. Do a radiograph on each sentinel node, hope that the clip node is there. We do frozen section, so if there is residual disease in any of those nodes, the patient would have an axillary dissection anyways. I would radiograph that axillary specimen as well. And if in the setting, I guess, where the sentinel nodes are negative, then I think provided, like we discussed, I was able to get 3 nodes, then I would feel more comfortable to not do an axillary dissection.
Yeah, and I think that's the idea. We all are traveling towards the same goal to try to minimize the need for axillary dissection. So if you don't get the clipped node, we do have evidence that we can just dual tracer map and retrieve 3 or more sentinel nodes. And alternatively for us, if we can't get 3 sentinel nodes and we know the patient has a clipped node, we will x-ray the nodes to see if we obtain the clipped node. And we're very comfortable omitting axillary dissection if we retrieve fewer than 3 nodes as long as we have the clipped node. So I think you don't want to just default to an axillary dissection if you can't find that clipped node. We have very good evidence that dual tracer mapping and retrieval of 3 sentinel nodes works, and at our institution we can do that about 93% of the time, get 3 sentinel nodes. And I'm going to skip this question because I have a whole lot of radiation questions for you down the line, Dr. Zellers. We're going to jump to this multifocal disease. 60-year-old female with multifocal right clinical T1 and 0 IDC, ER positive, PR positive, HER2 negative. She gets a mammogram and ultrasound. She has 2 distinct sites of disease, right 12 o'clock, 7 centimeters from the nipple, and right retroareolar. And the biopsy shows morphologically similar invasive ductal cancer. In this situation, she does get an MRI to confirm the presence of 2 distinct cancers with no intervening abnormalities between the 2 cancers and no other suspicious findings. She is interested in conserving her breast, and I'm actually going to jump here and talk to our patient advocate about this because I think it's an important question when we think about making these decisions for lumpectomy or mastectomy. What do you think is the best approach when we think about talking to patients about how we should manage their breast surgically?
Well, I think first you really need to find out from the patient, listen to the patient, find out what her lifestyle is like, and find out what her preference is, and give her the choices, maybe making sure that she has all of the information at hand so that she can make the right decision for herself. Most women don't want to lose their breasts, but they also want to get rid of the cancer. So it's sometimes you're caught between a rock and a hard place, but you're going to make the best choice that you possibly, if you have the right information. So I think it's important that she has all the information that she needs, and then it could be a partnership with her physician, her surgeon, about what she should do next. And bring in some psychosocial help for her also to help her with those decision making.
I think that's a fantastic point. I can't tell you how many people I see in my office who, with small tumors, are told they need a bilateral mastectomy, and the patient doesn't feel like she was given options to hear about something else. And having these conversations and understanding their values and what their preferences and their goals are really important in making the right decisions about the right surgery for that patient. Yes. So I'm just going to ask, we already heard very well that multiple lumpectomy is safe, and now we have good evidence that local recurrence rates are low. Dr. Zellers, would you ever offer that patient partial breast irradiation?
Hello? So I was thinking about this study today. Is it working? Okay. So this is a great study, and it is in line with what we're doing. Previously when these women had a whole mastectomy, we were treating the entire breast, right? Now we know that they don't have to have an entire mastectomy. That's sort of a tantamount to partial breast irradiation. We used to treat the entire breast with radiation. Now we don't. Now we can treat just partial breast. So I think this is in line with what we're going. I don't have any data yet about this. So until we have data, I would not do it. But I think it sort of follows the trend that we can be more localized with our therapies.
Perfect. And in the interest of time, I'm just going to move on to the next case and just ask you maybe one other question from that. This is a 57-year-old female, and we see this a lot, a history of coronary artery disease and a left-sided cancer. She undergoes a mastectomy, and she has 3 of 4 positive sentinel nodes and additional nodal disease in the axilla with a tissue expander reconstruction. I think one of the most common things that I get, and I try to remind my patients I'm not a radiation oncologist, is how we're going to protect their heart when we do post-mastectomy radiotherapy. And so I know we talked about protons, and although that's in the RADCOMP trial and that's being evaluated in patients getting nodal radiotherapy, what do you tell them when they're doing photon RT? What is the best method for cardiac sparing?
So I tell them that there's several ways that we can do it. We can use intensity modulated radiation therapy. It's not. Can you hear me now?
Yes.
Oh, you're going to regret that now. So there's a couple of ways to protect the heart. The first, obviously, is we can use intensity modulated radiation therapy, where we can shape the beam in one of the examples, and we can sort of curve the beam around the heart, around the chest wall, and we can limit the dose to the heart. Other tricks that we use is deep inspiration breath hold. By taking a deep breath, your chest wall expands, so your heart stays in place, your chest wall goes out, so there's greater distance, your breast or your chest wall is further from your heart, so treating the radiation is further to your heart. So that's another technique that we can use. Obviously, everyone's anatomy is quite different, and so we have to take that into account. I do want to caution you about the risk of heart toxicity. In the paper that was mentioned earlier by Darby and al., showing that there was a 7% increase with each gray of radiation, it is not an absolute 7%. It is a proportional 7%. So if the person's risk is 10%, it doesn't go from 10 to 17. It goes from 10 to 10.7. So there is an increase with radiation, but let's be realistic about the actual amount.
Perfect. Thank you so much. Yes.
I think the other thing that should be thought of is that to bring in a heart specialist who is familiar with cancer patients, so that that patient can be monitored very, very closely.
Agree. I think we have a cardio-oncology program. We're lucky to have that, not only for chemotherapy toxicity, but also radiation toxicity as well. That's a great point. We're going to move on to our next speaker. We're going to move on to the positive trials, so all you medical oncologists can take a breath that we are done with local regional. So Dr. Cynthia Villarreal, is currently the head of medical oncology at the Breast Cancer Center at the Tech Salud Hospital in Nuevo León, Mexico, and she's going to discuss the positive trial.
So, hello everybody. It's my pleasure to be here, and I want to thank the organizing committee for inviting me to give this presentation. Can you go to the first slide? Okay, so I'm going to discuss the positive trial, which is this study that assessed the temporary interruption of endocrine treatment in young women who are desiring to have a pregnancy. So these are my disclosures. So to put the trial into context, we have to recognize that breast cancer in young women who are those 40 years and younger comprises around 4% of cases in high-income countries, and its incidence is increasing. Moreover, young patients account for a major proportion of breast cancer cases and deaths in low and middle-income countries. And as we can see in the graph, in Latin America and the sub-Saharan Africa, they can reach up to 11 and 23% of the total of breast cancer cases seen. Even though in older cases it's more frequent, it's in young breast cancer patients, there's a 50% of young women that have luminal breast cancer subtypes. And notably, young patients are susceptible to receive more aggressive chemotherapy and endocrine treatments and prolonged hormonal therapies. These treatments can delay the beginning of reproductive life in young women, and this is especially important nowadays that there is a rising trend of delaying childbearing in the modern world. So even though the fertility and pregnancy-related issues are among the top priorities of breast cancer patients, there are still low rates of pregnancy in breast cancer survivors reported. And it has been shown that 60%, that breast cancer survivors have a 60% reduced likelihood of having a subsequent pregnancy compared to the general population. And here we can see that this contrasts with the fertility concerns of breast cancer patients, that at time of treatment decision making, it can reach 44 to 51 and 64% in the US, Europe, and Mexico. And alarmingly, 12% of patients can even consider receiving endocrine therapy for less than 5 years because of their fertility concerns. So the medical and the research community has found that this is really important for patients, and we have very important data that pregnancy after breast cancer is safe and it does not have a detrimental effect in outcomes in patients. But however, there is no prospective evidence, or there was no prospective evidence on the safety of temporary interruption of endocrine treatment to attempt pregnancy in patients with endocrine therapy that do not wish or are not willing to wait for 5 years. So the POSITIVE trial is the first international prospective single-arm study in premenopausal women wishing to become pregnant that had two main objectives that comprise breast cancer outcomes and pregnancy and offspring outcomes. So in this case, patients with ER-positive early breast cancer who desire a pregnancy were eligible if they had 18 to 42 years and had completed endocrine therapy for 18 to 30 months. They had a washing out period of 3 months, and they had up to 2 years break to allow conception, delivery, and breastfeeding, and the patients had to come again to endocrine treatment to complete the 5 to 10 years as the prescription of their physician. The trial enrolled between December 2014 and December 2019 in 116 centers in 20 countries in North America, Europe, and Asia, and the Pacific Middle East region, a total of 516 patients for the primary efficacy analysis. The median time from breast cancer diagnosis to enrollment was 29 months and a median follow-up of 41 months in this presentation. So as for the key patient characteristics, we can see that 43% of patients had an age between 35 and 39 years, 75% of patients did not have prior births, and importantly, 47 and 48% of patients had stage 1 and 2 disease, and it's important to mention that only 6% of patients in the trial had stage 3 disease. A bootstrap matching method was used to compare the positive patients versus the soft text patients as controls for breast cancer-free interval and distant recurrence-free interval analyses. So here we can see the results of the outcomes of the breast cancer-free interval events, which in the POSITIVE trial reached 8.9% and which are not different from the soft and trial results of 9.2% events at the 36-point landmark. And distant recurrence-free survival was 4.5% for the POSITIVE trial and 4.8%, which is not different from the soft and text. It is not noteworthy to point out that patients with 4 to 9 positive nodes and tumor size more than 5 centimeters had the breast cancer event at 3 years in 18 and 21% of cases, respectively. There was no difference in the 18-month landmark analysis and the time-dependent Cox model analyses of patients that become pregnant from those who did not regarding the breast cancer-free interval analyses. The pregnancy and upstream outcomes, there were 74% of the 497 women that had at least one pregnancy, 86 of those who became pregnant had at least one live birth, and only 11% of pregnancies had complications that were most commonly hypertension, preeclampsia, and diabetes. Birth defects were low in only 2%, 8% of the babies had low birth weight, 62% of women reported breastfeeding, but only 15%, but remarkably 15% had not resumed yet endocrine therapy. So as for discussion, there are several points to point out. So follow-up time is 3.6 years, in addition to approximately 2 years of the time period between diagnosis and enrollment. This might be insufficient time to follow up. We have to consider that in both HR positive and HER2 negative disease, the annualized hazard of breast cancer recurrence is greatest for the first 5 years, with a peak interval between years 1 and 2 after surgery. And this remains true for the premenopausal patients, where the peak of recurrence is in the first 20 months. But even after adjuvant endocrine treatment completion, women with hormone receptor positive early stage breast cancer still have a persistent risk of recurrence and death from breast cancer for at least 20 years after the original diagnosis. So longer follow-up is still needed. Another point that is relevant is that only 6% of patients had a stage 3 breast cancer, with a 3-year breast cancer event that reached 20% approximately. This is relevant because there is a higher proportion of young women that present with stage 3 compared to older patients, as we can see in the graph. And survival is inversely proportional to age, with the poorest survival rates among young women, particularly in stage 3. And patients with this stage show evidence of the highest hazard and largest magnitude of recurrence compared to women diagnosed with stage 1 or 2. So, can this population be safely encouraged to discontinue treatment to seek pregnancy? Finally, Latin American and African young women were not included in this trial, as we can see in the table. And it's unfortunately the case that Latin American and African patients still remain an underrepresented group in this and other clinical trials. This is important, again, because breast cancer is diagnosed at a younger age in these regions of the world and comprise a large proportion of patients diagnosed. And also, locally advanced breast cancer is frequently diagnosed in young women in these settings compared to high-income countries. And as we can see in the graph, it can account for 31, 32, and 38% of the total young women cases in Chile, Brazil, and Mexico, respectively. So the inclusion of patients belonging to underrepresented groups might have aid on the enrollment of different populations as stage 3 disease patients. So in conclusion, temporary interruption of endocrine therapy to attempt pregnancy among women who desire pregnancy did not impact midterm disease outcomes. Pregnancy can be safely achieved, and there was a low percentage of pregnancy and upspring complications reported. Longer follow-up time is needed to address the persistent risk of recurrence in HR-positive patients, but it is difficult to deliver strong recommendations in stage 3 young women who had a limited representation in the trial, but correspond to a significant proportion of patients, especially in low and middle-income countries. Inclusion of minority populations with a wider variety of types of patients and tumors could expand knowledge and applicability of results in real life. So what it will do on Monday morning, I would think that this study shows safety on the temporal suspension of adjuvant endocrine therapy as per the study guidelines in this follow-up, but it should not be a general indication for all patients, but a specific recommendation mainly for patients with an age limit for pregnancy, close to 40 years, and early stages of disease. For patients with stage 3 breast cancer, individualized and shared decision-making should weight risks, and it is imperative to encourage patients to return and conclude endocrine therapy. Acknowledgements to my colleagues and friends for their input for this presentation, and I thank you very much for your attention.
Do you mind pulling those slides back up? Thank you. So thank you for that great overview of the positive data. I think we were all very excited to see that today. So we thought we would present a case to put it into perspective and see what we'll really do when we're approaching patients in the clinic. So this is a 34-year-old nulliparous woman who presented with a 3-centimeter palpable breast mass. Biopsy reveals an intermediate grade, hormone receptor positive, HER2 negative invasive breast cancer. She undergoes upfront surgery with a lumpectomy and sentinel node evaluation and has a tumor that's a little over 3 centimeters, intermediate grade, ER/PR positive, HER2 negative with 1 out of 3 sentinel nodes involved. A genomic assay is sent and the Oncotype DX score comes back at 9. She also had genetic testing done, does not have any germline mutations. After it was a decision with her medical oncologist to do endocrine therapy and not chemotherapy, so she undergoes radiation and gets ovarian suppression and an aromatase inhibitor. But she just recently got married and is hoping to have children as she's not had them, and so comes to you to ask you how to think about this as she's just been started on endocrine therapy. So I thought I'd turn it to Cynthia to tell us a little bit about how she would have this conversation in terms of what would you say would be your ideal timeline for having a discussion about when to advise her to try to conceive. How long would you then actually wait to stop the endocrine therapy before she started to conceive? And when making therapeutic recommendations, would you avoid bisphosphonates in this setting? Sometimes we would consider bisphosphonate therapy in a node-positive patient getting ovarian suppression and AI, but would you consider that if she was going to try and have a pregnancy?
So again, she's young, so I would weigh the risks of not giving complete endocrine treatment. But if she wants to get pregnant, I would suggest to complete at least the time frame that the positive trial considered of endocrine treatment of at least 18 months. She has to have a washout period at least of 3 months as the positive trial. And I don't think we need to avoid bisphosphonates during the adjuvant setting. Bisphosphonates have around 1 week of half-life, so it would be enough to have a 3-month also of washout period for the bisphosphonate.
I think these are always challenging conversations, especially when we have such limited data. And I know there are different opinions about the bisphosphonates, and many people at our institution have been holding off on them, given that they can stick around. But again, it's a good point. We don't know, and it may be okay, but I think an important conversation to have. I think the other thing that often comes up is, let's say you waited, 2 years, and then she wants to go on and have a child. Would you think about offering staging scans before making that decision to discontinue endocrine therapy and try to conceive? This was not standardly done in the positive study. There were some providers who did offer staging scans to patients prior to enrolling on positive, but it was not uniformly done or recommended per the trial. So I think it is a conversation that needs to be discussed with the patient, and certainly, based on that patient's risk, but can be discussed and offered, but again, was not routinely done in the trial. So let's say she goes on, she stops her endocrine therapy, she goes on and successfully gets pregnant. What would you do in terms of breast cancer screening during the pregnancy? So Andrea, I'll turn it to you, maybe and get your opinion on this one. What would you do?
Medical oncologists don't like to order breast imaging. I've learned this at my own institution. I actually think that screening with mammography during pregnancy is very safe, and we know it's safe. I mean, I've spoken to our radiation safety officers, and the dose that is delivered to the fetus is minimal and well below what would be harmful to them. So I would not interrupt their annual imaging while they were pregnant. I would do annual mammography and ultrasound, but we do know that MRI should not be offered, as gadolinium is a Class C drug in pregnancy.
I think that's very helpful to know and think about. So I think the other question that comes up is obviously there are very limited patients with high-risk disease and positive, only 6% with stage 3 disease. How would you feel if this patient did have a more advanced cancer? How would your conversation change with this patient? So I'll turn it back to you, Cynthia, for this one.
So again, she's young. If she had a stage 3 disease, I would encourage her to finish her adjuvant treatment. But if she insists, she would need to know the risks. I think longer follow-up is needed, and there was very low representation of these stage 3 disease in the trial.
And what if the particular patient we presented hadn't been a candidate for monarchy, but what if her tumor was a little bigger and she had been a monarchy candidate or was high grade? And would you offer her adjuvant abemaciclib knowing that she does want to try and conceive? And if so, what would you think about timing of discontinuation of abemaciclib prior to trying to conceive?
I would definitely finish the the 2-year abemaciclib, and abemaciclib has a half-life of less than 1 day, so I guess 3 months would be, again, enough for a washout period, but we don't have a lot of information around that.
I think an important question now that our endocrine therapy paradigms have changed in the adjuvant setting, that we don't have data about this. Certainly there weren't probably large numbers of monarchy eligible patients in positive, but if this does come up, it does seem like you would want to get them through their 2 years of abemaciclib and make sure there's an adequate washout period. But what that is, we don't know, and certainly don't have safety data about that either. So finally, what if this had been HER2 positive or triple negative? Cynthia, how would your thoughts be here, and would you think about timing differently?
Well, regarding timing, as in the previous session was mentioned, at least 1 year has to pass by before recommending to have the pregnancy because of pregnancy-related complications. Stage 3 disease would need again to weigh the risks, but I think there's no other specific recommendation to be mentioned.
Yeah, no, it's a good point. I think we do typically think that these cancers do have earlier events, and so it's nice to try to get patients through at least 2 to 3 years and feel a little more comfortable that they're through a very high-risk period of time before then going on to conceive. And then, I think finally, these are challenging conversations with weighing risks and benefits and trying to put these data into perspective. And Vernal, I'd love to turn it to you to get your thoughts on and how you would advise us to approach these discussions with patients.
I was in the last session also, and one of the things that Dr. Partridge talked about was giving the chemo while they were in the second trimester of the pregnancy. And they found that, it really did not hurt the baby. They're following up with these kids. They're now 3 years old, but it didn't harm the fetus. They were able to get past, I think, 36 weeks. And she said that that was a pretty optimal time to give it in the second trimester, but not in the beginning and not at the end, to make sure you stop just before the baby is delivered. So I think if you give the patient all of the information that they need, and then work with the oncologist, the obstetrician, and the pediatrician, everybody needs to be in the room to have that conversation so that she knows what to expect and what she needs to do.
And I appreciate that. I do think having these discussions in a very transparent manner, and we do have to be honest about what the limitations of the data are, particularly with our limited amount of knowledge about what to do in the higher risk setting with stage 3 patients in particular. I think that needs to be made clear to patients that we don't have a lot of data here, but it's nice to see the safety, particularly in the stage 1 and 2 settings. I think that's very helpful to just be very transparent in these conversations. But thank you. We really did want to cover that because I think it's really nice to actually have these data to be able to inform patients and make decisions wisely. So we'll turn to our next segment. So we're going to shift gears a little bit and talk about antibody-drug conjugates. So obviously we've seen a lot of data over the past few days about ADCs, particularly in the metastatic setting. So we wanted to focus on the data that exists there, starting initially with the challenges with making pathologic decisions for ADCs, and then turning to the data in the metastatic setting and thinking about how to make decisions based on the data that we have and thinking about sequencing. So for our first speaker, we'll start off with the pathology. We have Dr. Poppy Siziopikou, who's professor of pathology and director of breast pathology and director of the Pathology Fellowship Program, as well as Northwestern University's School of Medicine and the Robert Lurie Comprehensive Cancer Center in Chicago. So thank you very much, Poppy, for joining us and being willing to attack this challenging conversation.
It's not working right now. Will
maybe So we'll actually dive into the medical oncology data surrounding the antibody drug conjugates in the metastatic setting, and then we'll turn back to the pathology. Do you mind taking down these slides and pulling up a different set? Oh, here we go. No. Oh, okay. We're next gonna go to Mariana Chavez-McGregor's talk. If you could pull those up. So Dr. Chavez-McGregor is a medical oncologist with a clinical practice that's focused on breast cancer. She's associate professor at the MD Anderson Cancer Center and has a primary appointment in Health Services Research Department and a joint appointment in the Breast Medical Oncology Department, and she'll focus on the antibody drug conjugate data.
Hello, everybody. Thank you so much for the invitation. I don't know if we can put the main set of slides on the screen. Going back to the main menu to pull on my slides. We can see what you are doing over there. Okay, so I'll probably get started just by sharing with you what I will be doing during the next couple of minutes. I was assigned the challenging task of talking about antibody drug conjugates. We heard a lot of exciting data about antibody drug conjugates during this meeting, and I'm going to try to put in perspective and try to answer the question, what will we be doing in the clinic on Monday. The role of antibody drug conjugates, it's actually not new. Antibody drug conjugates have been in development now for decades. And as you all know, they are mainly composed of a monoclonal antibody that is attached to a cytotoxic agent by a chemical linker. And we have actually 3 antibody drug conjugates approved today for the treatment of patients with metastatic breast cancer, with breast cancer in general, and those are TDM1 or trastuzumab and tamsin. We have trastuzumab deruxtecan, and we also have sacituzumab govitecan. And it's really going to be a challenge if I do all this without slides, but I will give it my best shot. So there are, and the slides were also very pretty though, but anyway, the trials that really led to the incorporation of all these drugs are well known to all of us in this field. So if we start with the HER2 positive field, we will think about TDM1, again approved 2013, and here we go. Now you guys get to see my disclosures, the beautiful slides that I told you about regarding the development of ADCs. And this is where I wanted to start, really thinking about the trials that led to the incorporation of these extraordinary agents into our treatment armamentarium, starting with the HER2 positive area, of course, Emilia, and the Destiny trials that we're going to talk a little bit more in a minute. In the hormone receptor negative or triple negative subgroup, it was ASCEND that led to the approval to sacituzumab govitecan, or SASI as we sometimes call it. And more recently, the TROPiCS-02 trial that led to the incorporation of using this agent in the hormone receptor positive, HER2 negative group. We all heard with a lot of excitement at ASCO 6 months ago about the HER2 low category, meaning 1+ or 2+, that really, with the data from Destiny-04, helped us think about incorporating trastuzumab deruxtecan in this field. So trastuzumab deruxtecan, as you all know, is a trastuzumab, monoclonal antibody that we're all familiar with, and the payload, it's a topo-1 inhibitor. We have very interesting data from Destiny-01 utilizing these agents after TDM1, and we heard in this meeting from Dr. Kropp the results from Destiny-2. Destiny-2, it's a large phase 3 randomized controlled trial asking the question of what's the potential benefit of trastuzumab deruxtecan compared to treatment of physician's choice in patients previously treated with TDM1. So we're talking talk about a third-line setting, and this trial demonstrated very important efficacy of trastuzumab deruxtecan with dramatic separation of the curves. You can see the great benefit of deruxtecan with a hazard ratio of 0.35 and a highly statistical p-value with curves that demonstrate very early on, demonstrated how efficacious this drug is, translating also into survival benefit. Now, we also heard in this meeting updated results from DESTINY-03. DESTINY-03 is a phase 3 randomized controlled clinical trial that evaluated the role of trastuzumab deruxtecan earlier on, in this case, in the second-line setting, comparing it with T-DM1. And Dr. Herbets updated the results demonstrating and confirming the superiority of trastuzumab deruxtecan over an already very good drug like its T-DM1 with extraordinary separation of the curves and a median progression-free survival 4 times greater in the patients that were treated with trastuzumab deruxtecan, and improvement also in overall survival, really confirming that trastuzumab deruxtecan is becoming our second-line treatment for the majority of patients in the HER2 setting. Just to conclude with the Destiny line of trials, Destiny-04 is the trial that we heard in ASCO, that it's evaluating the role of this drug in patients with HER2 low, confirming that compared to treatment of physician's choice chemotherapy, trastuzumab deruxtecan is superior. It is important to note that all these patients were, of course, HER2 low, and majority of them were hormone receptor positive. There were patients that were hormone receptor negative, but it's a small proportion of patients, and Destiny-04 confirmed that progression-free survival was better in patients treated with trastuzumab deruxtecan, and also improvement in overall survival, with an exploratory analysis amongst the small number of patients that were hormone receptor negative and HER2 low, but in that exploratory analysis, we saw improvements in progression-free survival as well as overall survival. Now, changing gears to sacituzumab govitecan, the other very exciting antibody-drug conjugate. This is an antibody against TROP2, and the payload is a topo-1 inhibitor. The ASCEND trial randomized patients with triple-negative breast cancer that had received at least 2 lines of chemotherapy to receive SASI or treatment's choice chemotherapy, and the trial was positive for progression-free survival and overall survival. The TROPiCS-02 trial was designed to answer the question of what's the role of sacituzumab govitecan in patients with hormone receptor positive, HER2 negative tumors, and compare that with treatment of physician's choice on patients that had already been treated with CDK inhibition and chemotherapy. The drug was superior to treatment of physician's choice chemotherapy for both progression-free survival and overall survival. So clearly, extraordinary drugs that have been incorporated to the use of our patients today. But of course, this brings a lot of excitement and a lot of questions. And a lot of them really relate to biomarkers, to prediction. Can we identify the patients that are more likely to benefit? I think when we think about trastuzumab deruxtecan, we know that patients that are HER2 positive clearly benefit from this drug. But as we hear more and more about HER2 low, we heard extraordinary presentations, some of those in a debate by Dr. Tolani, about, is this a new entity? How low it's too low? Can we treat these patients and receive benefit with HER2 ultra low? And we're going to hear in a minute about the issues associated with testing, associated with tissue. Is there a problem related to dynamic changes in the target? And how we can optimize treatment in our centers. As it relates to sacituzumab govitecan, I think it's very fair for us to ask the question, what is the role of TROP2 expression in terms of prediction, and whether those predictors can be different when we use them to treat patients with triple-negative tumors compared to hormone receptor positives, and whether we can eventually identify predictors for toxicities. We had the answers to some of these questions in this meeting. Investigators from Destiny-02 evaluated the concordance in HER2 low between historical and central results, and evaluated that about 78 for the samples went concordant. We can argue whether 80% it's good concordance or not, but that means that there's about 20% of the patients that wouldn't be really HER2 low. Probably more important from the clinician perspective was that they answered whether the median progression-free survival was different according to the characteristics of the tissue. And this is something that we ask ourselves in the clinic all the time. And what they observed is that whether the tumor tested was primary breast cancer or the metastatic lesion, patients still receive benefit in terms of the use of the drug. Similar answer, no differences according to whether it was archival tissue, new biopsy, and also it seems that the time of the biopsy or of the specimen, it's not necessarily that relevant. When we think about biomarkers for sacituzumab govitecan, we also had important data presented at this meeting. Dr. Rugo presented an exploratory analysis evaluating expression of TROP2 among patients participating in the TROPiCS-02 trial. What they did is that they evaluated membrane TROP2 expression in a CLIA-certified setting and evaluated the benefit of sacituzumab govitecan. They used H-score that went from 0 to 300 with a cutoff at 100. And what you can see in this slide, it's the curves evaluating the benefit of sacituzumab govitecan according to TROP2 expression, demonstrating that the drug is beneficial regardless of the cutoff that was used. Similar, these are the results for progression-free survival with similar results for overall survival, giving us an answer that on Monday, if a patient asks us if we need to evaluate TROP2 expression to determine efficacy of the drug, the answer will be based on this data. No. Now, very rapidly to conclude, we also are asking ourselves what's the role of these drugs in the early stage setting. There's clinical trials recruiting patients to really answer this, and we heard information from Dr. Barrio regarding the use of trastuzumab deruxtecan in the early stage setting, in a preoperative setting, with some interesting responses. This is still a small study, but I think we're going to hear more and more about that. So to conclude, we really need to think about how we are going to change our algorithms. I think for all those clinicians in the audience, we ask ourselves whether there's a clear sequence, whether patients with HER2 low tumors and should receive trastuzumab deruxtecan first or sacituzumab govitecan. We need to think about these very challenging questions in the setting of the need of understanding the resistant patterns to these drugs, resistant mechanisms that can impact the payload or the target. We do not know if we can use sequential agents that have similar payloads. There's some data suggesting that HER2 downregulation after trastuzumab deruxtecan could affect the efficacy of TDM1. So the reality is that there's a lot of questions to try to really optimize the use of antibody drug conjugates. So I think just to close and really to open things eventually for discussion, and I think for criticism to me, is my very rough attempt at an algorithm. It's far from perfect, it's very simplistic, but I think this is a way to start, and it's all my own personal opinion. I think in HER2 positive tumors, it's clear that trastuzumab deruxtecan is going to be used in second line with third line TDM1, and then also potentially tucatinib-based combination. Much more complicated what to do in the triple negative setting when we know PD-L1 determination is key. We cannot forget about the other biomarkers. We need to determine the BRCA mutation status on this patient, and immune PARP inhibitors is needed. My own personal opinion is that probably I will use sacituzumab govitecan before trastuzumab deruxtecan. The data from DESTINY-4, it's extraordinary. It's still 60-some patients in the hormone receptor negative group. Ultimately, I think what matters is sequencing all these agents, but of course, trastuzumab deruxtecan only amongst that are HER2 low. And just to finalize, amongst patients that are hormone receptor positive, and I see all with your camera, so I'm gonna, this may come back and get me, but it is key to think about endocrine therapy and targeted therapies, one or more lines. Remember the importance of determining whether patients have germline mutation or not. Many of us will start with capecitabine as first-line chemotherapy, thinking about the quality of life of our patients. And I think that's when we can ask whether patients have HER2-low tumors or not. Those that are should receive trastuzumab deruxtecan. Those that don't, chemotherapy. And then, of course, sacituzumab, a new treatment option for our patients. Thank you so much.
Oh, thank you very much for that excellent overview and for being able to present without slides for the first half of it. So excellent job. So next we're going to turn to the issues surrounding pathology, particularly surrounding HER2-low. So I'd like to introduce Dr. Calliope Suziapaku from Northwestern, who's going to give us an overview of that. Hopefully we can get the slides up.
Okay. Hello, everyone. This is something different. Okay, let's pull up the presentation.
There we go.
All right. So I'm very aware that it's almost 7 p.m. on a Friday night. After 4 days of an intense and very informative symposium, nobody wants to hear pathology, right? So I'll keep it extremely, extremely tight, only 3 or 4 slides to discuss. So as a pathologist, when I was coming to this meeting, there were a number of issues that I had to consider and think about the pathology issues that we are going to take into consideration when we are thinking about the HER2-low space. Again, as we all know, for the last 20 years or so, the discussion was, are we in the pathology laboratory able to identify this HER2-positive patients. We didn't want to miss anyone who would benefit from the anti-HER2 targeted therapies. Obviously, as we discussed multiple times during this meeting, with the DESTINY-04 results and other similar studies, now we have a bigger task to also identify these HER2-low patients. And so, again, as the representative of the pathologist in this meeting, walking into this meeting, if you asked me 3 or 4 days ago, I was going to tell you I'm very concerned about our assays. These assays were not designed for this purpose. How about asking an assay to perform in a linear range when it was originally designed to perform in a logarithmic range? But I'm very pleased to say that after reviewing a set of very elegant presentations during this meeting, these are the 3 questions that the pathologists were asked to consider, and I'm going to give you a couple of conclusions from those very elegant studies. The first question was, can we rely on the current assays to accurately pick out the HER2-low breast cancer cases? The second question to consider was, is there a consistent HER2-low expression throughout a patient's journey? How important it is to test the original biopsy? Should we also test the excision? Should we test a metastatic site? What are we doing? And then the last question, which is the most important of all, are there levels of expression that are so low that actually the patient is not going to benefit from these new therapies? So the first question, which is how are our assays doing, are answered very elegantly by a number of studies, including the ones I have on the screen. The first study was by Pratt and collaborators, and it was the evaluation of the concordance at the DESTINY-Breast04 trial. And these investigators reported a 78% concordance between the historic and the central HER2 assessment using the Ventana 4B5 immunohistochemistry assay. The second study was by Dr. Viale's group, and that was a global multi-center study, 13 sites, 10 countries, again using the available immunohistochemical assays, and these investigators were able to report an 87.5% between historical and rescored HER2 the HER2 assessment of the HER2 low cases, and they also reported similar concordance regardless of which method you were using. And then the last pathology study that caught my attention was the study by Dr. Rushoff and collaborators. Again, a real-world global study, 80 pathologists, 65 labs, US, Europe, Japan, Australia, Brazil. These pathologists were asked to review 75 cases, use the current criteria, 2018, and report the results. And again, the concordance for this study for the HER2 low cases was above 80%. So these data demonstrate the pathologist's ability to achieve acceptable, and the emphasis is on the acceptable, not ideal, not the best ever, but acceptable levels of accuracy for identifying HER2 low patients using our current assays when we very carefully apply the 2018 ASCO CAP criteria. Now, 80–85% is very good, is not perfect, so we have lots of work to do. We need to do what else can we do in order to push these levels of detection even higher, but we have a very good starting point. So Monday morning when we go to the clinic and talk to our clinical colleagues, we are going to tell them we can reliably help you with a huge percentage of patients, and we are working at the cutting edge of science to help identify the remaining patients that may qualify for HER2 low. So for the second question about how stable is this HER2 low expression, again, we had a number of very elegant pathology studies in this symposium. The first one that caught my attention, I'm not a big proponent of autopsies by any means, but this was an autopsy study. And we almost rarely talk about autopsy studies in this symposium, but these investigators did an autopsy on 6 patients that had HER2 low breast cancer. They retrieved 13 to 16 samples per patient, and they reported a discordance between the primary and the metastasis in all patients. And if they focused on different lesions from the same organ, they found HER2 zero and HER2 low in every organ, in every patient. The second study that caught my attention was a study by Carrido Castro and collaborators, 110 patients with triple-negative breast cancer. These investigators had 50 paired samples between the original needle core biopsy and the residual disease post-neoadjuvant chemotherapy, and 48 samples between the original diagnosis and metastasis. Again, in both cases, there was discordance between 0 and HER2 low in at least 50% of patients. And the most common conversion was from HER2 low to 0, but both directions of conversion were documented. And the last study was based on the results of the Penelope B by Denkert and collaborators. Almost 1,200 patients, they had post-neoadjuvant samples. 60% were HER2 low, 40% were 0. Again, they saw a shift. 37% of tumors changed along the patient's journey. 14% went from 0 to low, and 23% from low to 0. So these data then, if we consider all of these studies together, demonstrate that heterogeneity of HER2 expression was seen in all patients. This obviously complicates therapeutic decision-making because it would have been easy if the expression stayed stable, so we consider one specimen and be done, but apparently this is not the case. So there seems to be instability and evolution, and the patients are presenting with multiple different results over time. So it's not as if your pathologist makes mistakes and one time tells you this is positive, next time they tell you this is negative. This is the nature of the disease. So instead of a single number, we should probably view this expression sort of like dynamic over time. And we should consider HER2 low a tumor that showed some HER2 expression in any prior specimen. And the last question was, how low can we go? Are there cases where we have such low HER2 expression or maybe conceivably even almost none at all, that these patients then are not going to benefit from our new therapies. And again, we had some information about novel quantitative assays. This group of investigators, led by Dr. Petro Coyne and collaborators, used reverse phase protein array technology, laser capture microdissection, and they evaluated and they reported that 30% of ER negative and 40% of ER positive tumors with HER2 score 0 seem to express, if you look quantitatively, seem to express a modest amount of HER2. And this percentage is about the same, about 30%, of the people that showed response in the DAISY trial, although supposedly they were HER2 0. So these new technologies, and like these, many others, need validation, obviously, in larger clinical trials, and may help define the lower limit of HER2 low in order to see the therapeutic effect. So with this sort of like summary of the pathology studies presented at this meeting, I will stop and we'll continue our discussion.
Thank you very much. It's a challenging topic to think about which patients are truly HER2 low. So I thought we'd just ask a couple questions that I think come up all the time with regards to patients that we see in clinic for consideration of ADCs. So Mariana, one case that I think comes up all the time is if you have a patient who has metastatic triple-negative disease, they have a tumor that's PD-L1 positive and HER2 low. In the first-line setting, they get chemotherapy and checkpoint inhibition, and then upon progression, which ADC would you give?
I get the feeling you're giving me the opportunity to revise my algorithm, but I think I'm going to stick with it. So I think we have options, and ultimately, we can, of course, hear, patient advocate perspective. We just need to remember that we can sequence these drugs, and we don't have data to know which one is better. I probably personally will use sacituzumab up front. I think the data from ASCEND, it's stronger. It's a study designed for patients with triple-negative breast cancers compared with Destiny-4 that demonstrates that this extraordinary drug, it's efficacious, but again, it was exploratory analysis in a small group. So I will probably do SASI first and then deruxtecan, but I think somebody could think otherwise and will still also be okay.
No, I very much agree with you. There are 58 patients that were treated in DESTINY-Breast04 that had triple-negative disease, so it's not phase 3 data, although the data is very robust and consistent with what we saw in the hormone receptor positive group. I would, again, go with the level 1 evidence and use sacituzumab first and then use TDXD upon progression. But certainly that will leave us with the question of how does TDXD really perform after sacituzumab, and we do not have data for this at this time. It does bring up the question of how using topo-1 payload sequentially will work, and again, we don't know, and certainly there's a lot of planned studies to think about how to address that, but for now, I think we will clinically be trying it and see how patients do. I think the other challenge that comes up is when patients have metastatic hormone receptor positive disease and we see this evolution over time, how do we make decisions about which biopsy to use to make a decision? So for example, if you had a patient who had a primary cancer that was HER2 low, they develop metastatic disease, and upon recurrence are HER2 0, and let's say you even have a second biopsy that's done in the metastatic setting after 2 lines of endocrine therapy and chemotherapy that's HER2 0 again, would you think about TDXD for second-line chemotherapy in a patient who's had only primary tumor that's been HER2 low, but 2 biopsies in the metastatic setting that are HER2 0?
I think that probably I will be a bit uncomfortable. However, if we look at the analysis that was presented during the meeting, patients that were HER2 1 or 2 plus, meaning HER2 low, in the primary specimen benefited from the treatment. So if we go from that analysis, I think we could be comfortable at least trying. Like everything, we need to individualize and see whether the patient's symptomatic. We might start a drug and then follow them maybe a little closer. with scans, and it really highlights the importance of working in multidisciplinary teams and bringing our pathology colleagues to the table to really discuss what can be the best answer for the patients, and of course informing our patients of the potential limitations and challenges based on the changes that we know are also real. We also know that happens.
And also from the pathology perspective, a bone specimen may not be the best specimen to check, to use in order to check for HER2 expression, because we decalcify these specimens with chemicals that in many instances destroy the expression of these markers. So a 0 may not have been a 0 in another setting.
No, thank you. It is true, especially in the hormone receptor positive setting. Sometimes the biopsies we get are just bone biopsies, so helpful to think about viewing that with caution. So thank you very much for taking on the challenge of ADCs. Now we'll move to a very simple topic about what to do after CDK4/6 inhibitors. So Tanya Fem was very lucky to get this topic. So Dr. Fem is a gynecology oncologist from Germany. She actually not only performs breast surgery, but also manages systemic therapy. She's the head of the Department of Gynecology and Obstetrics at the University Hospital Düsseldorf and director of Comprehensive Cancer Center. So thank you for being willing to take this on.
Yes, thank you very much for the kind introduction, and thank you very much for having me on the panel. So what to do after progression on CDK4/6 inhibition? Just some few remarks. Based on current guidelines, endocrine therapy plus CDK4/6 inhibitor is a standard treatment for ER-positive, HER2-negative metastatic breast cancer in the first-line setting. However, the majority of patients will show tumor progression within 11 to 28 months due to therapy resistance, and PIK3A and ESR1 mutations contribute to this endocrine resistance. In current practice, sequential endocrine monotherapy or combination therapies are used in second, third line. However, we have limited prospective data to guide treatment decisions following clinical progression on CDK4/6 inhibitor. So what to do after progression on CDK4/6 inhibition? Here you see the European ESMO guidelines. The first step is, of course, after progression to do a somatic mutation testing using tissue or liquid biopsy, and a germline BRCA1 or 2 testing if not done before. In case of imminent organ failure, we should discuss with our patients chemotherapy in order to get a quick response. Otherwise, we have different options dependent on the results of the somatic mutation testing and germline testing, and is still an option to switch to endocrine monotherapy, fulvestrant or aromatase inhibitor, if not given before, but we know that the effectivity is very low. In case of BRCA1 or 2 mutation, we should offer our patients PARP inhibitor. Both talazoparib and olaparib have shown an improved progression survival versus physician's choice of chemotherapy. However, we have to note none of the patients had prior CDK4/6 inhibition or other endocrine combination therapies, including everolimus, for example, or alpelisib, and no survival benefit has been reported. A very good option for patients with PIK3A mutations is fulvestrant and alpelisib based on the positive data from the SOLAR-1 trial. Adding alpelisib to fulvestrant resulted in an improved progression-free survival of 5.3 months in the PIK3A mutated cohort. However, we have to consider only a numerical improvement in median overall survival of 7.9 months was seen in the mutated cohort. The discontinuation rate was very high, with 25% in the combination arm versus 4% in the fulvestrant arm due to side effects, and the most common side effects, grade 3, were hyperglycemia, therefore glucose monitoring is necessary, rash and diarrhea. And we have to note that only 6% of the patients had prior CDK4/6 inhibition. However, we know from the BYLieve trial, a phase 2 single-arm study, that alpelisib and fulvestrant showed clinical benefit after CDK4/6 inhibition by demonstrating a 6-month PFS rate of 50.4% and a median progression-free survival of 7.3 months. Another important option is endocrine treatment in everolimus in patients pretreated with aromatase inhibitors. There are no mutations required. We have 3 positive trials demonstrating that adding everolimus to endocrine treatment is associated with an improved progression-free survival versus endocrine therapy alone. We have to consider none of the patients had prior CDK4/6 inhibition. We observed a highest discontinuation rate of 19% due to adverse event in the Bolero-2 trial, and so no significant overall survival benefit has been reported. Now I want to move on to the new options we have to discuss, and one of the new options is maintaining CDK4/6 inhibition. We have learned from the MAINTAIN trial that maintaining CDK4/6 inhibition with ribociclib and switching endocrine treatment is associated with an improved progression-free survival of 2.5 months versus switching endocrine therapy alone in patients who had progressed on endocrine treatment and any CDK4/6 inhibition. However, we have to consider 87% of the patients received prior palbociclib, indicating that nearly all patients have received a switch of both endocrine treatment and switch of CDK4/6 inhibition. In addition, 66% of the patients were treated prior with CDK4/6 inhibition longer for 12 months, indicating a prolonged benefit from CDK4/6 inhibitor. The PACE trial has now presented in San Antonio this year. It was a negative trial. The investigators were not able to show a clinical benefit by maintaining CDK4/6 inhibition with palbociclib with a change of endocrine treatment to fulvestrant compared to fulvestrant alone in patients who had progressed on CDK4/6 inhibition and endocrine treatment. In this case, we have to consider that 90% of the patients were treated with palbociclib. Therefore, most of the patients only received a switch of endocrine treatment. So these are my thoughts regarding treatment with CDK4/6 inhibition beyond progression. We have received conflicting data from randomized trials regarding the clinical benefit. So, of course, more evidence is needed, and we have to wait for the results from the post-MONARCH trial and the Palmyra trial. Moreover, the role of switching both partners or only one partner, endocrine treatment or CDK4/6 inhibition, has not been answered yet. To my opinion, the most promising results are obtained in those patients with a switch of endocrine backbone and a switch of CDK4/6 inhibition from palbociclib to ribociclib due to the MAINTAIN trial, or from palbociclib to abemaciclib based on real-world data. Of course, a better understanding of the mechanisms driving resistance to endocrine treatment and CDK4/6 inhibition will help us clinicians to identify patients who will benefit from maintaining CDK4/6 inhibition beyond progression. Further new treatment options are oral SERDs. SERDs demonstrated in phase 1 trial single-agent activity with partial remission in heavily pretreated patients, including those patients prior CDK4/6 inhibition, prior fulvestrant, and in patients with tumors harboring ESR1 mutations. Currently, the role of SERDs as monotherapy or in combination with other targeted therapies, including CDK4/6 inhibitor, for example, or everolimus, is currently evaluated in numerous clinical trials. Here you see a summary of clinical trials currently investigating the role of oral SERDs as monotherapy in patients second line and higher. We have now 2 negative trials reported at the ESMO Congress 2022. They reported no progression-free survival benefit, and we have 2 positive trials, the SERENA-2 trial and EMERALD trial, and I want to go a little bit more in detail. The EMERALD trial investigated the clinical benefit of elacestrant over aromatase or fulvestrant in patients pre-treated with CDK4/6 inhibition. And as you can see here, elacestrant was superior to aromatase inhibitor and fulvestrant, demonstrating a progression-free survival benefit of 1 month and of 2 months in the ESR1 mutated cohort. We have now learned here in San Antonio that the duration of CDK4/6 inhibition was correlated with the progression-free survival. The longer the duration of prior CDK4/6 inhibition, the longer the progression-free survival on elacestrant or as compared with standard of care. In the SERENA trial, camizestrant was superior to fulvestrant with both doses, 75 milligram and 150 milligram, but we have to keep in mind that only 51% of the patients were prior CDK4/6 inhibition, and this might explain the higher median progression-free survival rates of 7.2 months or 7.7 months. And here are my thoughts regarding SERD. SERD monotherapy with elacestrant or camizestrant showed clinical activity in the second and third line setting, but with only moderate median progression-free survival benefit, and the OS data are still immature. We observed a very low discontinuation rate of about 3%, so the patients will tolerate it very well. It's interesting that 30 or 40% of patients show primary progression with SERD monotherapy, indicating complete endocrine resistance, and we urgently need biomarkers to identify these patients. To my personal opinion, patients with ESR1 mutation and or long duration of CDK4/6 inhibitor therapy probably have the greatest benefit from SERD monotherapy. The last option I would like to discuss is ACT inhibition in combination with fulvestrant, capivasertib. Capivasertib is an ACT inhibitor for all 3 ACT isoforms, and we have learned from the FACTION trial that the addition of capivasertib to fulvestrant significantly improved progression-free survival and overall survival in the overall population, but the effect was more pronounced in the ACT-altered pathway. However, in this trial, patients included were CDK4/6 naive. This gap of knowledge has now been addressed in the Capitello 291 trial, a phase 3 trial. This trial included patients who had progressed on prior aromatase inhibitor plus minus CDK4/6 inhibition, and this is important. No ACT pathway mutations were required. About 70% of the patients had CDK4/6 inhibitor pre-treatment. And as you can see here, adding capivasertib to fulvestrant resulted in improved progression-free survival of 3.6 months in the overall population and in 4.2 months in the ACT pathway mutated patients. These were the primary endpoints of the study. It's also important to know that the benefit from capivasertib was consistent across clinical relevant subgroups, including those patients with prior CDK4/6 inhibitor treatment. The OS data are immature, but there was a clear trend that capivasertib is associated with an improved overall survival. So here are my thoughts regarding ACT inhibition. Fulvestrant and capivasertib after progression on AI plus minus CDK4/6 inhibition demonstrates significant progression-free survival benefit in all subgroups, including in those patients with primary endocrine resistance. We observed a very moderate discontinuation rate of 13% versus 25% with alpelisib or 19% with everolimus. The most common side effects, all grade, are diarrhea and nausea. However, this could be very easily addressed. And we have to keep in mind that using this drug, we have to monitor blood sugar during treatment because a rate of hyperglycemia was observed with 16%. So what to do after progression with AI and CDK4/6 inhibition? This is a possible treatment algorithm for 2023, assuming capivasertib and elacestrant were approved. I discussed this treatment algorithm with Sarah. She was very helpful to find the right way. This pathway includes now the old options we discussed, PARP inhibitor, chemotherapy, everolimus, and the new options. And I would like to go through these new options for patients with either one wild type, mild progression, and no mutations which indicate CDK4/6 inhibitor resistance, probably switching endocrine treatment and maintaining CDK4/6 inhibition with ribociclib is an option. For patients with either one mutated tumors and prolonged benefit to CDK4/6 inhibition, elacestrant, of course, is a way to go. Capivasertib is open for all patients, but this is for sure an option for patients with ACT-mutated pathways and for those patients with reduced response to CDK4/6 inhibition. Thank you very much.
So that's a really, really complicated algorithm. But thank you very much. I think it goes to show how much this field is changing. So actually, if you could just leave the algorithm up, we thought we'd just ask our panel a couple questions, and then we'll open up questions from the audience to the panel. So I think in thinking about this question, obviously this algorithm requires one to get genomic information upon progression on CDK4/6 inhibition. I think access to getting genomic information may be different globally. Tanya, do you have the ability to get genomic information after progression on a CDK4/6 inhibitor, and is that something you would routinely do?
No, we don't do it on a regular basis in Germany. We are only able to pick PIK3A mutations and, of course, BRCA1 or 2 mutations.
And how about you, Mariana, in the United States? How is that working for you? Are you obtaining genomic information?
We do have access to that. And I think what we're trying to do is to also do it in a thoughtful way, not because we have access to it, we should necessarily order it, when it's not going to change practice, but we do incorporate that into our management of patients with metastatic breast cancer.
Thank you. Well, I would love to open it up to the audience for any questions. So please feel free to come to the microphone if you have one. I guess while we're waiting, one question that I think is going to come up is if you have a patient who has a PI3 kinase mutation and assuming capivasertib was approved, how would you approach that patient? Maybe Mariana, I'll start with you on this one.
I really think the toxicity profile of capivasertib, it seems to be more favorable compared to alpelisib, so that might move me towards using capi more than alpelisib in that group of patients.
It looks like Lisa, you have a question.
Yeah, Lisa Carey, University of North Carolina. So, just to be provocative, I worry that the clinical validity of HER2 low itself is seriously in question, even more so with all the heterogeneity that was documented. So, is the trick that you try and get your favorite pathologist to call something HER2-1? Please respond.
Well, I think I'll turn to our favorite pathologist on our panel here.
We aim to please. No, that's not the correct answer. I think that once the 2018 criteria are used appropriately, the correct answer is arrived at in the majority of cases. I'm aware that the ASCO CAP panel is going to issue soon some additional guidelines that will help us tease out the percentage of cases that we cannot handle at this point. So that would be helpful. There are also other things that can be helpful down the line. There are AI solutions that may be helping in these very difficult cases. And obviously, with clinical trials like the Destiny 06, we may decide that it doesn't matter and we would know the answer then. but there are many little tweaks that I think that in the next few months will be very helpful in order to classify these cases as accurately as possible.
Thank you. It's a very, very challenging question, and I think we don't have a perfect solution at this time, unfortunately. I'll take the microphone to my left.
Thank you so much. A quick question on the algorithm, the now I think will be famous algorithm. Would you, and I may have missed it somewhere, but would you put a patient who's progressed on chemotherapy, put that patient back on CAPI, or perhaps ribociclib, or with an ET switch, or what would you do if she's progressed on palbo before and chemo?
Sorry, so if you had a hormone receptor positive patient who got first line endocrine therapy, CDK4/6 inhibition, and then goes on to second line chemotherapy, but has a PI3K pathway alteration?
No alterations. Chemo done actually was low, HER2 low, Benon and HER2, and then what next if she progressed on that?
If she got TDXD?
Yeah.
I see. So get CDK, chemo,
Everything.
TDXD. What would you do beyond?
Could you put her back on CAPI? Would that be something that you would imagine following the algorithm?
Even without a pathway alteration, would you
Yeah.
think about it? I don't know, Cynthia, do you want to take this one on?
Well, no, I don't know. I think we don't have information on that, but I think that might be an option. Why not? But I'm not sure what is the answer to that.
Yeah, those patients that were more extensively chemotherapy pretreated were not eligible for Capitella 291, so we don't know what the activity would be in that setting. And I think particularly without a pathway alteration, I may not be quite as driven to try it in a late line setting, personally.
Now, just to add, the other agent that this patient could receive based on TROPiCS-02 will be sacituzumab govitecan, so that will be another great choice.
Great, that's wonderful. Thank you.
Thank you. I'll go to the microphone to my right.
Hi. So diverting from this topic, we had a paper about circulating tumor cells, and I wanted to know how you would like to integrate that information into management. There's a lot of buzz. I've been getting a lot of group texts from my institution back home about using circulating tumor cells to decide on first-line treatment in the metastatic setting.
Mariana, do you guys use CTCs?
No. Not regularly, of course, outside of a clinical trial.
Anybody else on the panel with a comment on that? I would say I also have just used them I've never actually used them clinically, but I do think the data seems strongest as a prognostic indicator at this time, but not so much from a predictive ability. I thought the data that was presented was very interesting, but given our paradigm of treatment has shifted from the time the study was done, where we now have CDK4/6 inhibition, it's hard to know how to integrate that into the clinic, especially now as we're moving towards more ctDNA utilization and genomic-driven decisions. But I think hopefully in the future we'll better understand. We do also have on our panel Dr. Meredith Regan, who's our biostatistician, and I don't know, Meredith, if you've had any comments. She's joining us virtually.
So thanks very much, Dr. Trelani, and so thanks to the organizers for facilitating this. We just didn't plan a way to communicate with one another to speak. But one thing I would love, a message I'd love to echo from earlier today when everybody returns to the clinic on Monday, is to remember the unique beauty of academic research. So much of what we've talked about in the last hour or two was academic research from the cooperative groups, from local trials, and I know they're a labor of love. The positive trial is a labor of love, and we've talked about that and how important that is to the care of patients. And so I hope that everyone, when they return to the clinic on Monday, will redouble their efforts to these labors of love in doing academic trials and academic research.
Thank you so much, Meredith. What a very important reminder. We'll turn to my left.
I'm sorry, I know it's taking a very long time. I'm Robin Shaw from Mexico City. I had a question about local control. Would you guys consider omitting frozen section when performing a post-neoadjuvant sentinel lymph node in the case of a patient who is clinically N1 who converts to N0 and who's being taken to breast-conserving surgery? Could it be an option just to wait for the final path report and just send her to radiotherapy instead of the axillary dissection?
Go ahead.
I think it's fine to omit frozen section and wait for the final pathology, but I think if the final pathology in that situation shows there's no residual disease, then that would be appropriate to move forward with radiation. But if it does show residual disease, including isolated tumor cells, then I would recommend that patient to do axillary dissection. Or, I think there is a clinical trial where anxiously waiting for the results, Alliance A11202, and until we know that, I would still do dissection.
So you'd still offer double local control with the axillary dissection and then the radiotherapy because of the clinically positive lymph nodes?
Yeah, we don't have any data yet from the Alliance trial, and until we do axillary lymph node dissection for any residual disease in the node after neoadjuvant chemotherapy is the standard of care. We cannot assume that that's going to be a positive trial or that there won't be subsets of patients who require or who have a higher rate of local failure without ALND. I think that the unanswered question is isolated tumor cells, and we don't see that very often, and they were not eligible for the Alliance trial. And so in that setting, I think you do have to individualize that. I think if frozen section isn't available to you, then you can choose to not do it, but I do think that it is also a huge burden to the patient if your risk of coming back is high to have to subject them to 2 operations.
Thank you. Oh, thank you. Turn to the right. Oh. Thank you for being very fair.
Hi, Ethan Sokol from Foundation Medicine. I was curious how in the post-CDK4/6 inhibitor setting you consider, or if you consider high tumor mutational burden.
Good question. Does anyone want to take that? Mariana?
I think the mutation burden information is super interesting, and maybe at some point we're going to take that into consideration. I don't see me including that into my practice or treatment algorithm at this point, but clearly some area that should be further studied.
I will say our group has had a lot of interest in this area, and certainly, we do technically have pembrolizumab available to us for patients who have a TMB over 10. We had done some work also looking at ipi-nivo in this setting, and also actually found the majority of those patients in that study were actually hormone receptor positive, and several of them have had very prolonged responses in CR even after discontinuation of immunotherapy. So I do think it's something to think about. I think the challenge is how do we integrate it, along what point in time. I do worry about as we get more pre-treated, that's where immunotherapy is maybe not going to do as well, and so maybe trying to figure out how to stick it in between endocrine therapy and chemotherapy in a very high TMB patient, particularly those lobular cancers who do tend to have high TMBs, is worth keeping in mind. So it's a good reminder. Go back to
First
the
off,
right.
Meredith, so much thank you for your comment about the importance of doing things that are hard and sometimes not well compensated. Rich, all right, so you told us who you don't want to use hypofractionated protons in. Who do you want to use protons in, period? What's your algorithm for using protons?
So the role of hello, working? Good.
Maybe use the mic at the table.
I don't think they can hear you.
So that's a great question. The protons are already in use now for post-mastectomy radiation. There's single-arm, single institutions showing that it's okay, and that the toxicity is may be associated to poor treatment planning, which we've learned about and we've improved. But there aren't any large studies looking at protons in this setting. So I would wait until the RAD-COMP trial is out, where they're comparing photons to protons in breast cancer patients before I use it standardly.
Oh, thank you. Well, thank you everyone for your attendance on this late Friday evening. We really appreciate it. Have a great rest of your night.